Hi, today reflection is a case of laparoscopic ventral mesh rectopexy. So this lady actually has a prior outmire procedure first many years ago, followed by a DeLorme procedures, which she had recurrence despite that. She's now 76 years old. She had no previous abdominal surgery, just only the previous outmire and also DeLorme procedures. Because of that, clinically, she's still having obvious rectal prolapse on straining. It's a complete rectal prolapse where the rectum is protruded out of the anus, and she had some anal tone laxity because of chronic prolapse. So she's subjected for this laparoscopic ventral mesh rectopexy. As you can see, in this case the small bowel is slightly dilated over ileum region. Okay, the liver is slightly cirrhotic. I put in a port on the right iliac fossa and the left lumbar, and then assistant port on the other side. So over here I'm trying to retract away the small bowel where it come to the view to assess the sacral promontory, and see the uterus is slightly bulky for a 76 years old and having a lot of fibroid actually, and in fact the gonadal vessel also slightly engorged. Attempting to displace the small bowel out of my view, putting her into a head down position, okay, but she cannot tolerate too much of head down, so I put in a gauze trying to maintain a consistent small bowel retraction, but I failed to do a nice retraction. Decided to put in assistant port. In this case, in the end I put in 2 assistant 5mm on the other side. Alright, this patient also preoperatively the rectal prolapse was actually maintained outwards. Okay, so in this position actually the rectal prolapse is maintained outward. Okay, all right. So over here trying to fix a uterine traction sutures. Okay, the straight needle in. Right, trying to put a uterine suture. Over here the uterus is slightly bulky for a 76 years old. Right, through the uterus. Right, and then tie it over. First, to delineate the sigmoid properly, so actually attempting to mobilize the sigmoid a bit from the previous, probably related to previous dissection from the outmire, this from the Asians. Here delineating the lateral mesentery of the sigmoid mesocolon. Okay, lifting up the rectum. Okay, trying to dissect from the second promontory. Over here, can see the second promontory down. Okay, the right ilia and the ureter on the right side. Okay, and that's the second promontory. Opening up the space. Can see there are some scarring over the reflection here, probably related to previous outmire procedures, and very lax recto sigmoid mesentery, as you can see. I'm also trying to preserve some nerve if possible, but there was some scarring over this region and laxity of the sigmoid, rectal sigmoid. making it slightly confusing for me. Having said that, this is actually my first ventral rectal complete VMR. In this case, assisted by my senior, Dr Hazim, who had more experience than me. You can see I'm trying to reduce the rectal prolapse and delineating the cul-de-sac. Right, reducing the anterior rectal prolapse. You can see that now the sigmoid mesentery is very redundant. Okay, strengthening the rectal tube. Okay, there's some bleeders on the mesentery, trying to secure the bleeders. Couldn't pinpoint well. Later on, I decided to change to a Maryland to stop the bleeders. Right, as you can see, the sigmoid is really redundant. Okay, it's keep on flopping down and trying to get a good view on the distal rectum. Okay, for dissection at the distal rectum. Okay, alright, okay, here. Okay, trying to open up the plane in the posterior mesorectal fascia. There's actually some scarring here, leading to difficulty to get into this plane. As you can see, I got into the plane. Okay, opening up the mesorectal fascia. There's a left iliac actually showing up. Okay, just delineating the anatomy. Okay, very difficult to get the traction because of laxity of the pelvic flexion. Okay, and it's also looking at this, it looks like there's a scarring in the pelvic flexion. Okay, encounters some bleeding, worried I might be in the wrong plane. Okay, so I'm trying to delineate the anterior plane actually. Here getting a bit more challenging to get the view, closer to the distal rectum, and with the very floppy rectum and the sigmoid. This case is slightly more challenging because also the uterus is slightly bulky at this age. You can see the uterus is slightly bulky. Again, straightening the tube, trying to get to the anterior cul-de-sac. Slightly more challenging here, looking at the very deep cul-de-sac hidden by the bulky uterus. Right, so here I'm getting into the rectal vaginal septum, opening out the space. Right, getting the view of the rectal vaginal septum. Okay, opening out the space. Challenge over here is really how to get a proper view on distal rectum when the rectum and the sigmoid is so floppy. Also, the small bowel also is sort of floppy. Okay, trying to dissect down the distal rectum and the rectal vaginal septum. Going further down to the distal rectum near the perineal body. As you can see, when going down deep to the pelvis, the view is getting more and more tricky. The cameraman has to turn the light source upside down to get the deep pelvic view right over here. Okay, over here maybe scarring. Further dissect, cleaning the fat on the anterior rectum and the distal rectum. Alright, cleaning, dissecting the low rectum free from the RE fascia. Okay. Here, trying to fix up the other side of the uterus to maintain a better view for proper suturing. You can see even with this, the view on the distal rectum is still slightly limited. More reason because of the uterus with the fibroid. Here, trying to put in the mesh, cutting the mesh. Okay, putting down the mesh. Alright. Here attending to suture. As you can see, the cameraman is fighting with me for low pelvis suturing. Is really challenging. Here, attempting to suture again. Okay, making a bite on the rectum. Okay, here using a PDS sutures. Making a loop. Tie down. Okay, cut away the sutures. Some hole of the distal rectum is achieved. Okay, a few more sutures to get a good fixation of the mesh on the rectum. Alright, it's getting shorter a bit. It's a bit challenging to again apply the knot. Okay, okay, changing the sutures, applying under the 3 sutures over here. Okay, here trying to tie off another sutures, apply higher level. This is a fast forward 4 times reduce. The in actual real life is really challenging. Even trying to loop around these monofilament sutures. This can be really challenging, especially low down in the pelvis, and with the assistant trying to get a view and fighting you with the space. Right, almost done. Over here, trying to apply the last stitch in on the distal rectum. can see getting confused slightly at times because the monofilament sutures is long, can be challenging, but if it's too short also it's not easy. Getting the right angle. Feel the loop again. Found the T still deep again. Can be tiring at times, but insisted for good fixation. Redo it again. Tie down again. Right. Okay. Then remove the needle, trying to fix the proximal side. Straighten the rectal tube. Okay, fixing to the promontory. Trying to fix properly to the promontory here. Trying to get a good bite. The presacral fascia. Okay, going through. The fascia. Okay, trying to tie down the mesh. Orientating the needle again for the good loop for suturing. Over here you can see some tenting of the mesh, some tension applied on the distal rectum. Alright. Okay. Over here we decided to put some tackles. Okay. Here's the tackle being placed on the sacral promontory. Okay. Some minor oozing. Okay, decided to just stop it there and put a gauze. Yeah, to secure the hemostasis. And then we trying to fix the redundant colon in a manner that it's actually lie lateral rather than redundant in the pelvis. So this end result of the fixation. Okay. I think in this stage D is having a redundant colon at the sigmoid, and so how we actually tack it laterally, hoping that it avoid too much of descent. Here cutting the trim the mesh. Okay, finalizing the fixation, then going to close the peritoneum. In this case, we put in some fixation glue on the distal rectum to allow a better fixations of the mesh onto the distal rectum, right? And additional one on the sacral promontory. You can see the tension applied on the distal rectum. And even the right ureter and right iliac is well seen also here. Okay, trying to flatten the mesh here and applying some glue over here. Yep. Okay, trying to fix the mesh proper on the promontory. Okay, suturing started to close the peritoneal fold. Okay. Again, challenging towards the end, also tiring. There might be some poor movement, but trying to improve. Closing the peritoneal fold. Step by step. Trying to get a good catch on the peritoneum fold. Okay, closing halfway the peritoneum. Again, trying to get a good catch. Okay, making sure the ureter is away. Almost complete closure. Before you hear some glue from body trying to take out. Closing the last few bits of the defect. Almost covered entirely the mesh. Okay, trying to reverse the needle. Reverse the bite. Okay, and cut it long. Removing the needle. Then final check on the bleedings. Okay, looking good. There's no bleeding seen. There's again the area of the sigmoid tag and the redundant sigmoid is seen. making sure there is no risk of torsion. Okay, removing the stay here. Okay, securing hemostasis on the stay sutures. Yeah. Alright, thank you very much.